Hey guys, welcome to Podiatry Practice Mastery. Don here. I'm going to talk about tip number 3 from 20 out of 20 here from the AAPPM meeting. I had a lot of conversations with people about shockwave or EPAT, and specifically, what I recognized is that we do quite a bit of shockwave, and I know there's many doctors that are still uncertain if they need it, or if they'll benefit their practice, or if they're going to use it enough. So my two takeaways: number one, there was a colleague I was talking to, and he was doing 6 treatments and doing them a week apart, and he was having better results, or much improved results. And that was actually initially my idea. When I started out with shockwave, I was doing 6, and I think it was because I watched a lecture by a guy named Paul. He's a shockwave expert from the UK, and he recommended 6 treatments. And but now I've kind of toned it down to 3. So let me explain. If someone has pain, I usually say if it's over 3 months, 3 to 6 months, then 3 is enough. If it's over 6 months, then I need to do 6 because it's more of a chronic. The tissue is changed. But what I usually do is I do 3 first, and then I do a 6-week break, then I do another 3. What I found is that this 6-week break, then another 3, I really don't do 6 that many times. It was actually more beneficial for me to do 6 in a row. But I'll tell you, my personal, inside of me, my personal, reservation to doing this is, first of all, getting 6 appointments on the schedule, because I'm still doing them, is a lot of appointments, and it kind of gluts up my schedule. And then also, almost like pre-deciding for patients what they should and shouldn't do is an issue. I do have some other friends that do have assistants do the shockwave. In our practice, we don't have the assistants do it, but that's one way. The other way would be increasing the price. I was talking to someone recently, and my buddy Larry, and Larry was talking to someone, and there's focused shockwave, there's radial shockwave, and then there's this, I think it's called EMTT. It's a new type of electrical shockwave. I'm not sure, we don't do that one. But the thought is, when they're doing these treatments, instead of charging $200, which we charge for a radial and focused, charging $300. So at $300, then it makes it at a price point that you could realistically do it for the patients. And kind of the thought in my head is, patients don't really care between $200 and $300. They just want the results. So if $300 is going to get the results, then they're willing to pay $300. And so that's kind of the thought. But right now we're still doing for both, for the $200. So the first takeaway was it's like switching it and upping it to 6 appointments. I did that in the beginning. I'm not doing it as much, but that's something that could work. The second is, I was talking to a doctor, and he has shockwave, but he just doesn't use it. And it's because I think he prejudges his patients what they can pay, and really what it comes down to is confidence and belief in it. And the way I've learned to do this, I learned this from a guy named Dan Sullivan. It's called the 4 C's. So the 4 C's are commitment, courage, capability, and confidence. So commitment, courage, capabilities, and confidence. So it's like a circle of how you learn things and do things. So the first is commit. So I was mentioning to him, you have to kind of commit to doing shockwave. You have to have courage initially, and then your confidence is going to develop. So and the confidence in the device or in that new treatment modality isn't going to come until you have the courage. The way you can reduce the amount of courage you need, I recommend, is when you're learning shockwave, is to do it for free initially, or doing it at a reduced rate. What I did is, initially, I just did it on everyone for free, because we own the machine. So I did it for free so I could develop confidence that it actually worked on my patients. And I did the same thing with ultrasound. Initially, I did just I did block time of ultrasound. Everyone got an ultrasound, did it for free, just so I could learn how to do it, build my confidence. So I think that's an area that we can do. You do it for a period of time, and you maybe advertise it that way for for 30 days or something like that. You're doing it on everyone for free. And so you can see the results and you can kind of compare it, and that'll build your confidence. So commitment, you have the courage to do that. The way to reduce the amount of courage needed is you do it for free. Why? Because if you're charging full price and you're not confident, then you're not going to do it. You're not going to offer it. So many times you have patients that would benefit from it, but you're never offering it to them, so you can't see if it works or not. I've been doing it so much and I kind of know how to do it, then I have the confidence. I'll explain kind of the contrary to that. There's an area in my practice which is laser treatment for fungal toenails. Okay, I have no confidence that works. I know the laser companies are all going to be mad, but I have them all. Okay, I have a I have a Cutera. That was the initial one, and I think that's a heat laser. I have a Lunula as well, which I rented because I still don't believe it works. It might work on certain nails, but I just don't see the benefit. And then I also have a Remy, which I don't use as well. I could be wrong. If you guys think differently, please reach out to me. If you totally say, hey Don, this works much better than Lamisil. I talked to certain people at this meeting, and they're doing the laser with the Lamisil. And my thoughts to that is, well, if the Lamisil works, why add the laser besides for financial gain? So if it's only for financial gain, I'm not going to be able to sleep that well at night, but these are just my opinions about these things. So in terms of going back to Shockwave, doing it and practicing it on patients to build your confidence level so that you can do more of it. And so I know I'm at a phase right now, the way I do it on any kind of anything, such as any tendinitises, metatarsalgias, things like that. Everything except probably like neuromas. I don't find it works that well on neuromas or neuropathy. But I do the Shockwave kind of first line for patients. Another error I used to make is with Shockwave. I used to wait till the end of all the other treatments. So patients would come in, I would treat them. I would see them for plantar fasciitis, for example. I would do all the cortisone injections, physical therapy, everything, and then at the end I would do the Shockwave. So what I've done is I've kind of put it to the front line of my treatments. If you want to see how I do this, you can go to patientpresentations.com, and then there is a tool called the Patient Presentations tool, and it's basically just slide decks on everything I treat. Look up the one on plantar fasciitis. You're going to see how I kind of explain it to patients. It does have a patient treatment checklist of how I treat things, and I kind of go through that with my patients, and you can use it on your patients. I'd like you to tell me what your thoughts are and how that works for you. Okay? Once again, thank you for listening to Podiatry Practice Mastery. Please like or write a review so other people know about it, and share this with others. Okay? Thanks, guys.